Good evening, everyone. Thank you for joining us for this edition of Premier Health's Breast Cancer Myths and Facts webinar. This evening, we have the pleasure of having Dr. Neha Sarvepalli to present the information on myths and facts to you. Dr. Sarvepalli is a graduate of the University of Illinois College of Medicine at Peoria in Peoria, Illinois. She completed her general surgery residency at St. Louis University Hospital in St. Louis, Missouri. She has completed an additional fellowship focused in breast surgery at William Beaumont Hospital in Royal Oak, Michigan. Dr. Sarvepalli is a member of the Society of Surgical Oncology and the American Society of Breast Surgeons. She has received advanced training in performing nipple-sparing mastectomies and oncoplastics. Her focus is on management of breast cancer in high-risk patients. I now welcome Dr. Sarvepalli.
Thank you, Kristen. That was a very nice introduction. So I thought a little bit about what I could present for today that would be informative and actually helpful for everybody that is attending today. And I felt like maybe doing some busting of some myths and talking about some of the misconceptions people have about breast cancer would be helpful. So I'm going to go through some of that, and I'll also talk about how each breast cancer is treated a little differently so people can hear about some of the options that occur and make decisions based on that. All right. So the first myth I have is that breast cancer is rare. I imagine that everybody knows, but this is false. It's a busted myth. About 300,000 women are diagnosed with breast cancer every year, and it is the highest incidence of cancer in women, and the next one is lung. It is the second highest mortality rate if you look at all cancers for women. About the average woman has a 12.5% risk of developing breast cancer in her lifetime. So by the time of 85 years old. And we know that as you get older, there's an increased risk of breast cancer. So by the time that someone is 80 years old, they have a 1 in 8 chance of developing breast cancer. So there's many theories about why this happens. One is that there is shedding and changing of the life cycle of the ductal cells, and they get tired, and that mistake happens, and that's how a cancer cell is born. And we'll talk a little bit more about that. So over a lifetime of shedding and growing of these ductal cells, the mistakes sort of accumulate, and we see breast cancer happen. So there are some risk factors for breast cancer. Some of these things are things that we just cannot change. So one is increasing age, like we talked about. Female sex, women have a higher incidence of breast cancer than men because of our estrogen exposure, which is our third risk factor. Women that have early onset of their periods or late onset menopause have had estrogen within their body that's been lingering for a lot longer, so they have an increased risk of breast cancer. Nulliparity, meaning no children, will increase your risk of breast cancer because pregnancy is actually considered protective. There's more progesterone in your body during that time than estrogen. And we cannot control our genes. So we know that BRCA1 and BRCA2 increase your risk of breast cancer, and having a significant family history increases your risk of breast cancer. So those are things that we cannot control, but there are some things we can control regarding our risk for breast cancer. And one is we can change the obesity level. So we know that obesity increases your risk of breast cancer because we carry active estrogen within fat cells. So replacing some of the fat cells with lean muscle improves our chances of avoiding breast cancer. Alcohol consumption, tobacco smoking also increase our risk of breast cancer. So avoiding those can decrease your risk of breast cancer. And decreasing estrogen exposure. So some of the things we talk about, we can't control, but we can avoid hormone replacement therapy following menopause unless it's absolutely needed, or decrease the amount of time that we take that hormone replacement therapy for. There has been some studies that have shown that shift work, so nurses that work late at night, also have an increased risk of breast cancer. This has been studied, so it's probably related to stress and anxiety. So shifting that away from night shift for women or older women can also decrease the risk of breast cancer. Another risk factor that I hear a lot about is, does aluminum-based deodorant increase my risk of breast cancer? And this comes up often in my practice. And the one thing I'll say is that there is no established link between antiperspirants and breast cancer. This is a statement that was put out by the National Cancer Institute, who studied this and found that there is no increased risk. I do tell patients that if they have concerns about aluminum-based deodorant, that to avoid it. It can sometimes cause skin irritation and increased sensitivity. The other reason that this might be a myth that has been around for a little while is that we do tell patients to avoid deodorants prior to mammograms. And the reason is we see under the armpit, we can see what looks like white dots, which is similar to how cancer presents when you get a mammogram. So avoid the deodorant before a mammogram, but you can use aluminum-based deodorants without concern for breast cancer. The other question I always get is, do soy products increase my risk of breast cancer? So this is been studied. We know that about 85% of breast cancers are estrogen dependent, which means they grow because they see estrogen in our body. But soy contains phytoestrogens, which are not the same as the estrogens that are produced in our body. So breasts do not respond to these phytoestrogen like it does to the natural occurring estrogen that's within our fat cells that comes from our ovaries. So there is no reason to avoid soy products if you have an increased risk of breast cancer or if you've been diagnosed with breast cancer. In fact, using soy as a source of plant protein is actually good for you. We know that some smoked meats and high fat animal products increase your risk of breast cancer. So soy is a good alternative for those. Another myth I have is, if I have breast cancer, I would be able to feel it. Unfortunately, this is not true. So most breast cancers are not palpable. And by the time we can feel a cancer, it's approximately 1 centimeter in size, or the size of a lima bean or a frozen pea. By the time a cancer is 1 centimeter, sometimes we're looking at more aggressive treatments. So that would involve chemotherapy or doing increased radiation treatments. So self-exams are great, but they're not a substitute for mammogram, because we do want to catch these before they become 1 centimeter or bigger. Another myth that exists about mammograms specifically is that they expose patients to unsafe levels of radiation. This has been studied, and they found that that is not true. 1 mammogram is equivalent to about 0.4 millisieverts. So what does that mean? That means that it is equivalent to living on this planet for 7 weeks and being exposed to background radiation. And there have been many studies that have been shown that the benefits of mammograms far outweigh the risks associated with radiation from a mammogram. So radiation, unfortunately, is not a good enough excuse to avoid mammograms. But I have no family history of breast cancer, so I can't get breast cancer. This is also untrue. Most breast cancers just happen sporadically, which means that they just happen out of the blue. About 80% of breast cancers happen that way. And only about 5 to 10% of breast cancers happen because of a genetic mutation that is seen within the patient or their family members. So there are some genetic factors that increase your risk of breast cancer. One is the BRCA1 gene or the BRCA2 gene. These have been well studied and well publicized, and they increase your risk of breast cancer by almost 50 to 70%. There's other genes that have also been discovered in the last 10 years, such as the PALB2 gene, the CHEK2 gene, and CDH1, which all increase your risk of breast cancer by up to 40%. So if there's a significant family history, we do encourage patients to consider getting genetic testing. It used to be that patients that had breast cancer had to fall into very stringent guidelines to be able to get genetic testing. So they had to either be very young at the time of diagnosis, have had more than one breast cancer during their lifetime, have a what we consider more aggressive breast cancer, which is a triple negative breast cancer before the age of 60, have a male breast cancer or Ashkenazi Jewish ancestry. That is no longer true. So through Premier, we are doing more genetic testings for patients that have a significant family history of breast, ovarian, and colon cancers by offering them myriad genetic testing. We work with our genetic counselors to help get that covered or partially covered if insurance doesn't qualify you. Now, we also have changed who gets breast cancer or genetic testing if they have breast cancer. The American Society of Breast Surgeons put out this guideline in 2017 that says that we should offer genetic testing to anybody who has been diagnosed with breast cancer. So I offer it to all my patients. And the idea is that if there is a gene that hasn't penetrated, so hasn't affected multiple family members, we're still able to catch it so that the other family members can undergo genetic testing and can start screening earlier. The reason this becomes important is because patients who are high risk for breast cancer, we can offer them alternating mammograms and MRIs so that they're getting some sort of imaging of the breast every 6 months. Now to get to the bulk of this talk. So there is a misunderstanding that all breast cancers are treated in the same way. This is untrue. The breast cancers that we see are treated very differently based on where they start and what factors they have. This is an anatomy of the breast, and you can see that there's lobules. This is where milk is made in the body. And there's tubes, these are ducts, that carry milk from the lobules to the nipple. So that's how, as a breastfeeding mom, you're able to breastfeed. We know that certain lobular cancers, that's where milk is made, they tend to show up a little bit not as prominently on a mammogram. So patients that have lobular cancers may need additional testing, like a breast MRI, prior to starting treatment. And that's one way that breast cancers can be different. Another way is there's a difference between invasive and non-invasive breast cancers. We talked about cancer cells or breast cells getting tired and making mistakes. So here we see a cross section of a tube where milk is carried from the lobules to the nipple, and they're lined with these cells. These cells line a lot of tubes in our body, and they're constantly shedding and growing. And in the breast, they respond to hormones that they see. So over a lifetime of shedding and growing, you can have mistakes that happen, and that's how a cancer cell is born or an abnormal cell is born. When that abnormal cell is just filling the tube but hasn't broken out of the tube, we call that a non-invasive breast cancer, or DCIS. But when it breaks out of the tube and goes into the fatty portions of the breast, here you can see this, the red cells are breaking out of the tube, we call that invasive ductal carcinoma. And the reason that's important is DCIS and invasive ductal carcinoma are treated differently, and we are able to do less treatment on some of these non-invasive breast cancers and just follow them without doing radiation. The invasive cancers, they've broken out of the tube, they have an increased chance of going elsewhere, so we are more aggressive with what we offer the patient. The other big factor that comes up is the estrogen and progesterone receptor. This is a molecule that's tested on every cancer cell. It tells us what the cancer cell is responding to. So the majority of breast cancers are estrogen and progesterone receptor positive, which means they respond to hormones that they see within the body that gives them the cancer cell a signal to grow. We like when the estrogen and progesterone receptor are positive because we do have medications that we can give you to block that and essentially starve the cancer cell so that it doesn't get the signal that's telling it to grow. Not to get into the weeds, but another receptor is a HER2 receptor. And this HER2 receptor can also give the cancer cell signals to grow. And we now have medications that we can give that target that specific receptor and decrease the chance of that cancer cell growing. So when I think about breast cancer, I think about what am I doing for the breast and the lymph nodes under the armpit, and what am I doing to treat the whole body? So where I come in, I'm a surgeon, so I work on removing the breast cancer at the breast level. So there are multiple options for breast surgery, and this will be dependent on the kind of cancer that patients develop. So one type of surgery is a lumpectomy, where the cancer is removed and a rim of normal tissue is removed around it. And usually this is not enough, because if there's a cancer, if we removed this area here and there's a cancer cell, a single cancer cell sitting here, we haven't gotten that cancer cell. So typically when you get lumpectomy, we also recommend radiation. That's not always true, but that's typical. The other option is to do a mastectomy, where we actually remove the breast, and we can have multiple options for reconstruction at that time. So I have a special interest in oncoplastics, which means that we try to reconstruct the breast in such a way that the patient doesn't have a constant reminder that they have breast cancer. Really believe in breast preservation and maintaining the contours of somebody's body. So in this picture, you can see that this patient had excess breast tissue, had been looking for breast reduction for a while, and was diagnosed with breast cancer. So we used the breast cancer as an opportunity at that time to remove the cancer and also provide a breast reduction at the same time to allow for symmetry. So now she has what we call an oncoplastic breast reduction. So she gets the lumpectomy, which is a cancer portion of the surgery, and then she gets a reduction and a lift to help with the excess breast tissue that she has. Some patients decide to undergo mastectomy and get reconstruction at the same time. So this is an example of undergoing a mastectomy, where we remove all the breast tissue under the skin. We save the skin envelope, and a plastic surgeon comes in and places an implant under the skin. In this case, we did not save the nipple. There are some instances that we do try to save the nipple if that's important to the patient and does not compromise the cancer care. Another option, the more common option after a mastectomy, is to have an expander placed, which is essentially a deflated water balloon. This deflated water balloon is attached to the muscle under your skin after the mastectomy, after the breast tissue is removed, and it's slowly filled over time, just like a water balloon is. And then the patient has to go back for a second surgery to have the expander removed and have a true implant placed. And that would be the final portion of their surgery. There's also another option for patients that want to avoid any foreign object in their body, and that is an autologous reconstruction. This is where we have the patients take some of their own skin, muscle, and use a blood vessel within the abdominal wall or in the back, and create a new breast. So here, this was fat and muscle from this area of her belly that was taken and placed as breast tissue up here, attached to the blood vessels going into her chest. There are many women that are also coming to me now to discuss doing a mastectomy without reconstruction. There's a big movement called the aesthetic flat closure movement, where we try to close the skin as close as possible to as flat as possible, so that there's no excess tissue on the sides or extending over the belly. This allows for a more comfortable fit for breast prosthesis that eventually the patients would get fitted with. So another question that comes up a lot is, do I need to have my lymph nodes checked under my armpit? Typically, this is done by injecting a radioactive dye and a blue dye at the time of surgery to find the first draining lymph node. What this does is it gives us information of whether the cancer has gone anywhere else in the body. because the first place it would go before it would go anywhere else in the body is under the lymph node or under the armpit in the lymph nodes. Not every patient needs to get a lymph node surgery. So there is a new guideline that says early breast cancer, so small breast cancers that are estrogen and progesterone receptor positive, can avoid a lymph node surgery. And we look at the patient, we look at their morbidity and their projected lifespan, and we make that decision after talking to the patient. Now, there are some patients that we have to remove all of the lymph nodes under their arm because they had a lot of disease in that area. This used to be the standard of care. We used to do this for most patients, was to remove all of the lymph nodes. We don't do that anymore because we found that it increases your risk of lymphedema, which is swelling in the arm. Here you can see that there's different stages of lymphedema. And there's some ways that we can counteract that. We can have the vein and the lymphatic vessel attached together by a plastics microsurgeon to decrease the risk of lymphedema, but it still remains high. It's almost 30 to 50% after having an axillary lymph node surgery. So we try to avoid this, but in some patients that need it, we have to go ahead and remove the bulk of the disease. So that would involve removing all of the lymph nodes. Now, radiation is very different than what it used to be 15, 20 years ago. It is very targeted, so that only the breast tissue is affected. You lay on a table that looks like this. It's a CT scan looking table, and X-ray beams go across the affected breast only. It's sort of like laying on a tanning bed in that you feel some light and heat and warmth to the area. And there are some side effects of a sunburn or blister type reaction, and very, very small dosage affecting the heart and lungs. And that's the reason it's different now, is because we try to avoid that. So this is an example of an external beam radiation. Radiation after a lumpectomy, like I said, most patients that undergo a lumpectomy are recommended to undergo radiation to treat the rest of the breast tissue that was left behind. After a mastectomy, most patients don't need radiation unless they have more disease burden than we expected at the time of surgery, or they have lymph nodes under their arm that come back as positive, in which case we do recommend radiation after a mastectomy. The first question I get after a diagnosis of breast cancer is, who needs chemotherapy? So chemotherapy is a very nuanced discussion, so I don't want to get too in the weeds about it. But most patients that have high-grade tumors that have an increased chance of recurrence are recommended to undergo chemotherapy either before or after surgery. There are certain tumors, the triple-negative tumors and the HER2 positive tumors, we also recommend undergoing chemotherapy and immunotherapy because we know it improves overall survival. The other question that comes up is, who needs hormone replacement or anti-hormone treatment? These are the patients that we talked about before that have that estrogen and progesterone receptor positive in their breast cancer. They would benefit from this because it would allow us to block that signal and starve the cancer cells if they've gone anywhere else in the body. This is usually referred to as a chemo pill, and we ask patients to take it anywhere from 5 to 10 years. And the side effects are similar to going through menopause, so hot flashes, joint aches, night sweats. But most women are able to get through the treatment without debilitating side effects. So that was a lot of information to cover. I wanted to leave plenty of time for questions. The big take-home points that I wanted to get across during this presentation is I want everyone to just be kind to themselves. It is hard to remember to get a mammogram because we're busy with our normal lives with work and being moms and wives. But if you can take an hour out of your year to get a mammogram, we do know that it saves lives. It allows us to get to the cancer early so we can treat it early with least invasive treatments that we have. And do your best to control the factors that we can control to decrease your risk of breast cancer. So, increasing exercise, avoiding red meats and smoked meats, increasing or having a more plant-based diet. We know will decrease your risk of breast cancer. And then if you do think that you have an increased risk of breast cancer based on your family history, reach out to your family medicine doctor or your OBGYN to see if you would qualify for additional testing that would include genetic testing. And if you do, or you're found to have an increased risk, we ask that you see a breast specialist to see if you would qualify for enhanced screening. That would be a mammogram or a breast MRI as needed. That's all I had.
Thank you, Dr. Sarvepalli. Everyone, if you have any questions, please enter those questions into the chat now for our Q&A part of the webinar. I'll give everyone a couple minutes. Dr. Sarvepalli, we have a question. Can you talk about the fast breast MRI and when someone should have one?
Sure. I'm so glad that this came up. There are some patients that do qualify for additional testing, but maybe have not met their deductible or are just under what the insurance company considers as high risk. So we do offer fast breast MRI. It allows us to do the same thing. It allows us to examine the breasts a little bit closely, and it's an out-of-pocket cost of about $400, and Premier offers that here so that we can get some of these other patients screened.
Another question came in and they are asking, does breast cancer typically or always come in the form of a lump?
Does breast cancer always come in the form of a lump?
Yes.
So no, unfortunately, most breast cancers don't always present as a lump. And I always think of breast cancers that I can feel as being more aggressive, or we're behind the eight ball a little bit. The non-invasive breast cancers just show up as calcifications on a mammogram, which almost looks like salt was sprinkled in the mammogram. And those you cannot feel. That is the non-invasive breast cancers. The invasive breast cancers you can feel as a lump. But again, by that time, we're now talking, do we need to do chemotherapy? Do we need to do radiation? When if we had caught it earlier, we could maybe avoid some of those more invasive treatments.
Are self breast exams still recommended for women and men?
So I always say that you're going to know your breasts better than anyone else. So I recommend patients who are postmenopausal, so they don't have a period anymore, to do a self breast exam, both standing up in the shower and laying down, because the breast changes based on how you lay, at least once a month. So pick the first of every month and do it. Mostly because it gives you self-awareness. It has, and for women that are premenopausal, I say do it right after the completion of your period. There is no good recommendations to continue doing monthly breast exams on your own because it's found that it increases the risk of having more biopsies and more unnecessary testing. So if you're not confident in doing your own breast exam or you're unsure, I say you have to have at least one good clinical breast exam. So either the OB-GYN does it or your primary care provider does a good clinical breast exam once a year.
Do women who take birth control pills for several years have an increased chance of getting breast cancer?
Yeah, there's a theoretical risk that certain kinds of birth control pills that have unopposed estrogen can increase your risk of breast cancer. All in all, I say anything that you can do to decrease your estrogen exposure will help, but we can't always do that. Another question that comes up a lot is can I do hormone replacement therapy? Is that going to be counter to me being able to get my breast cancer treatment? This has also been studied. There was a lot of like studies that came out in the 90s that said putting patients on hormone replacement therapy increases their risk of breast cancer exponentially, and we should avoid it at all costs. But now we say if you're really having postmenopausal symptoms, hot flashes, night sweats are affecting your day-to-day life and quality of life, I do say we should start hormone replacement therapy. We have to reevaluate at least once or twice a year and see if we can sort of taper or come off of it. Having it without any sort of end date is where I start to worry.
Can women who have um, breast cancer, for women who have breast cancer and elect to have a mastectomy or total mastectomy, can they later get reconstruction done
Yeah,
once?
that's a good question. So, patients that undergo a mastectomy and we don't preserve the skin, so we are not leaving a skin envelope behind, they're not really eligible for a expander placement or an implant placement unless they're willing to go through a pretty painful process of expansion. So most of the times, patients that decide to have a mastectomy with no reconstruction at that time, we say that they are eligible for reconstruction using their own tissue, so they can do an autologous reconstruction. And I usually defer to my plastic surgery colleagues to have that conversation.
And are the plastic surgery colleagues in surgery with you typically, or how
Yeah.
is that process planned out?
So if there's any uh, inkling that somebody wants to do reconstruction, I have them meet with plastic surgery to discuss their options. So whether they're planning to do implants, whether they're planning to do their own tissue for reconstruction, just so that they can hear what that would involve. And at the time of surgery, when I'm doing a mastectomy, the plastic surgeon comes in after I'm done removing the breast tissue to put the implant in or put the expander in. So it is done at the same time as surgery, but the final reconstruction often takes up to a year to be done.
Does having breast implants prevent and or complicate finding breast cancer with mammograms?
No, that's an excellent question. So, um, there is a protocol that we use for patients that have breast implants so that we can still evaluate their breast tissue, and it's the implant displacement protocol. So they actually try the radiology tech will move the implant out of the way so that they can still get the majority of the breast tissue in the mammogram machine to be able to take the mammogram. Uh, if there's any concern, we'll also get a breast MRI, which gives us more information. It's extra sensitive in finding things, but can sometimes result in unnecessary biopsies because it's not very specific. But no, it does not hinder us being able to do the mammogram.
And from a male's perspective, well, how do you recommend men check for breast cancer?
I would say it's similar to how women do it, that you just move in circles away from the nipple areola and see if you can feel any palpable masses. It will be much more obvious in a male to be able to palpate breast cancer because they don't have excess fatty tissue in that area like women do. So it's a little bit more easy.
And are there criteria for getting a 3D mammogram versus just the standard mammogram? Is it based upon age? What are the guidelines for that?
So the 3D mammogram is another tool we have to be able to screen patients a little bit better. So luckily here at Premier, we do all of our mammograms with 3D reconstruction. So you can sort of scan through the breast, and it allows the breast radiologist to see if something is smoothing out as they move through the breast, or is it sort of stay still like a cancer would. But it's a better tool. So if you can get the 3D mammogram, which most women do now, that's a better tool than a standard 2D mammogram. So that's what I would recommend.
Is it a myth or is it actual data that supports that breast cancer can be caused by high levels of stress?
It is not a myth. I mentioned one study that looked at night shift workers, and it was felt that that might be related to increased risk of or increased cortisol levels. So we know that stress can increase just increase cancers in general, increase your risk of cancers. Specifically about breast cancer, it hasn't been studied, but my suspicion is that if somebody had studied it, it would be high, then it would be a high rate of correlation.
At what age or between what ages does breast cancer seem to be more aggressive in women?
It's really hard to say that we know that women that are diagnosed with breast cancer at a younger age tend to carry either a gene that makes them have a more aggressive breast cancer, or because it's unusual, they should have the defense mechanisms to be able to get rid of cancer cells within their body. So at earlier age, we tend to see more aggressive breast cancers, but it sort of spans the whole spectrum.
Do women who were previously diagnosed with breast cancer and have survived chemo and radiation, are they able to breastfeed if they become pregnant later in life?
Yeah, it really depends on the surgery that happened. So if you undergo a mastectomy, all the breast tissue has been removed, which means that there's no ductal tissue that would carry the milk from the lobules to the nipple to be able to breastfeed. Uh, and there's no lobules that make milk. But if you have a lumpectomy, there's a pretty good chance that you'll still be able to breastfeed. The problem is, are the ovaries functional after undergoing chemotherapy to be able to get pregnant, to be able to make the hormones necessary to make produce milk?
If someone's family member was diagnosed with colon cancer, does that put them in a higher risk to potentially get breast cancer?
So no, there's not really a single gene that has looked at colon and breast specifically. We know that CHEK2 is one that can increase your risk of colon cancer and increase your risk of breast cancer. So that's something you could check for. But just having colon cancer in a family member is not, usually a risk factor in itself for breast cancer. But if you have the genetic mutation, which is the CHEK2 mutation, then you can.
Many people have fear when they have had a mammogram and get called back in and scheduled for a ultrasound. What does the ultrasound entail? Can you elaborate on that, please?
Sure. Yeah, this is an excellent question. So, the mammogram gives us a sort of one picture. So, it gives us a general picture of what may be abnormal within the breast. The ultrasound is very good at looking at a specific area, saying, hey, we are concerned based on the mammogram about this area. Let's look at it more specifically. And it gives us more information about what the characteristics are. So is this a mass that looks more just like a simple cyst that we're seeing on a mammogram, or does it look more like a cancer? Does it have jagged edges? Is it, what size is it? So it gives us a good way to measure the size. It tells us if it's vascular or not vascular. We know that a lot of breast cancers have vascularity, so you actually have blood vessels going up to the area, so it makes us more suspicious. It's also if we can see it on an ultrasound, we prefer to biopsy it under ultrasound because it's a little bit more comfortable than doing a stereotactic biopsy, which is a biopsy where we have to use a mammogram machine to do the biopsy, and you actually have to lay on your belly and put your breasts through an opening in the bed to be able to get that biopsy done. So if we can see it on ultrasound, we prefer to biopsy it under ultrasound.
If there is no family history of breast cancer, at what age should a woman get her first mammogram?
Great question. So at the age of 40 and yearly after that is a recommendation from the American Society of Breast Surgeons. And for women that have an increased risk of breast cancer, we actually say 30. You can start getting your mammograms at the age of 30, along with the MRIs, or 10 years before the youngest family member. So if somebody was diagnosed at 45, like mom was diagnosed at 45, you can start getting mammograms at 35.
One topic everyone talks about is gluten. Is gluten linked to breast cancer?
I have not heard that before, so I don't think there's any real data about gluten and increased risk of breast cancer.
All right, that wraps up any questions that we may have. I will give the attendees a couple minutes just in case someone is going to enter another question into the chat.
Thank you so much. I hope this was helpful.
All right. No more questions in the chat have come through. Thank you so much, Dr. Sarvepalli. You did a wonderful job. Very informational. For everyone who is on the webinar, we will also send out the video this week so that if you want to share it or if you want to rewatch it again, you can. Thank you and have a good night.
Thank you. Get your mammograms. Have a good night.